Our next speaker is Dr. Marianne Jamieson, who's an associate professor in the Department of Obstetrics, Gynecology, and Pediatrics at Queen's University in Kingston. She completed medical school at McMaster University, and after residency, went back to Queen's for obstetrics and gynecology. She has a fellowship in Louisville, Kentucky in pediatric and adolescent gynecology. While she is a general gynecologist who cares for adult women, Dr. Jamieson has a busy practice in the pediatric and adolescent gynecology subspecialty and has a clinical and academic focus in contraception, teen pregnancy, as well as the gynecologic care of women and girls with inherited bleeding disorders. She was one of the original co-chairs of the subspecialty committee for pediatric and adolescent OBGYN at the Society of Obstetrics and Gynecologists of Canada, and the first Canadian to be elected president of the North American Society of Pediatric and Adolescent Gynecology. She's a core member of the multidisciplinary Women and Bleeding Disorders program in Kingston, and along with hematologists Dr. Paula James and Mariana Silva, and nurse specialists Lise Thibault and Stacy Shannon. Welcome, Dr. Jamieson.
Thank you. Thank you very much for having me. I do not have any disclosures or conflicts of interest. I want to talk to you today about that 12-year-old. Or maybe she's 18, maybe she's 30, maybe she's 45, who comes to the emergency department with 3 days of flowing like a tap and soaking pads every 30 minutes. Now, she's depleted herself. She is tired. She is short of breath. She is pale. Maybe she's tachycardic. Maybe she's hypotensive. This is the patient I want to talk to you about today. And I imagine are there patients here? If you put up your hand, if you're from a patient perspective? Great, okay, thank you. You as patients or healthcare providers will be better informed about gynecologic causes of this acute heavy bleeding and how to investigate the acute heavy menstrual bleeding and to be aware of treatment options, but also to try to how you choose from those treatment options. I'm going to talk a little bit about transitioning from that acute situation when you get control to prevention of another catastrophic bleeding episode, but I draw your attention to a breakout session today by my peds gynecology colleague, Dr. Tanya Dumont, who's talking about heavy menstrual bleeding in a breakout session. So we are in the presence of royalty. I was very impressed that there's a lot of people in this audience who are very high achievers academically. But I just want to, sorry if I'm not pointing over there. We have a European journal publication called The Evaluation and Management of Acute Menorrhagia in Women with and Without Underlying Bleeding Disorder, a consensus from an international expert panel. And there we've got Dr. Andrew James and we've got Dr. Rochelle Winikoff here. And since we're over time, I kind of joked that I could just drop the mic now and tell you to go read and walk off the podium and we'd be done. But what's really nice is they got together in 2009 because there was a paucity of literature on how to manage this acute bleeding. And they tried to look at the literature and come up with a multidisciplinary expert opinion piece. And what they included, which was really cool, is they have like a tick box checklist to guide your history, your physical, your investigations. They have some first line, second line treatment options, and they've got some doses in there. They have, I understand from Montreal, a prototype of a pre-printed order sheet so that once you get into this situation, you can automate things and things won't get missed. Blood work won't get missed. Treatment won't get missed, vitals won't get missed. And finally they go on, this was all under the pretense of women who have either no bleeding disorder or an unknown bleeding disorder. So they went on with the rest of the publication and gave you some guidelines for treatment options when you know what you're dealing with, whether it be von Willebrand's or a thrombocytopenia, dysfibrinogenemia, etc. So I'll try to do it justice and bring some of my agenda to you. There are gynecologic conditions that I said can cause this emergency heavy menstrual bleeding without a bleeding disorder. And when you have the combination, look out. ovulatory dysfunction, which I'll talk a bit about in a minute, breakthrough bleeding on hormonal contraceptives. So that doesn't tend to be life-threatening bleeding, except in the population with bleeding disorders. Pregnancy loss, it's not really included in that consensus. They don't include obstetric stuff, but I think it has to be in your differential diagnosis. Fibroids and polyps, which I'll talk about briefly, and a condition called adenomyosis. So adenomyosis is like an engorged, very glandular uterus. It's well known to cause heavy bleeding, painful periods, and pelvic pain and pressure. It happens in women in their 30s and 40s, not so much in adolescents, nor do fibroids and polyps happen very often in adolescents without African descent. You have to think about vaginal trauma, and while they excluded malignancy in that consensus, I really believe that when you have a patient hemorrhaging in the emergency department, you have to at least think about cervix cancer and at least think about uterine cancer or the pre-malignancy condition, hyperplasia. So not all heavy menstrual bleeding that's acute will harbor one of these conditions, especially if you have inherited, acquired, or anticoagulated bleeding coagulopathy. But the flip side, just so we say it, is not, these aren't all the gynecologic conditions that come to medical attention more often in women with bleeding disorders. I alluded to it before. They are more likely to present with symptomatic endometriosis. They are more likely to present with recurrent hemorrhagic ovarian cysts. So I said I wanted to take a moment just on those two different etiologies, the ovulatory dysfunction and the fibroids and polyps, just briefly. So again, apologies to that side of the room. In the first few menstrual cycles, and in fact, right at menarche, and in the perimenopausal transition years, there can be a tendency to very chaotic, heavy bleeding. So what's supposed to happen is we're supposed to have the first half of the menstrual cycle proliferate the endometrium. Then we're supposed to ovulate, and that ovary produce 2 weeks of progesterone. And when that progesterone level falls, we're supposed to have a nice synchronized, complete self-limited slough of the endometrium, which I guess with a bleeding disorder can still be heavy, but it's supposed to be organized and functional. And what happens is if you don't ovulate, you keep getting more and more proliferation from the estrogen. And let's say you ovulate, but you only ovulate about 3-4 times a year. You can imagine that this may be pretty thick in there, or you don't ovulate at all. And that's where you can get into this, as I said, thick, lush endometrium conceptually breaking off erratically. And it can be a cause of acute menstrual bleeding crisis. Menarche is that kind of a bleed physiologically, and people who have other conditions known to prevent regular ovulation, like polycystic ovarian syndrome or obesity itself, can present with this. I also wanted to just take a moment and remind you about fibroids and polyps, because I think this is really important in your differential diagnosis with or without an inherited bleeding disorder. I'm just going to draw your attention, because we'll talk a little bit later about treatment options, that you can have multiple intramural fibroids, but I want to point out this particular breed right here. So this is an entirely intracavitary isolated fibroid. That is a potential cause of very heavy menstrual bleeding, and I'll mention later it can be missed on a regular ultrasound, whereas most ultrasounds will pick up the other multiple fibroids. So we have this patient. She's, as I said, in the emergency department. Your history is going to, most of you, I don't have to teach you this. This is about menstrual history, medical history, something as simple as she's on chemotherapy and she's pancytopenic, or she's anticoagulated, or she's had a past history of a DVT. These may be important. I don't have to tell you how to screen for bleeding disorder and medications and recent trauma. It is well recognized that we can be called to the emergency department after a sexual encounter with a tear at the top of the vagina, and if you have a bleeding disorder, you're more likely to come in very pale and hypotensive. When we're thinking about things, I'm also thinking about desire for pregnancy now and in the future, the need for contraception, and what treatment options have they either succeeded with in the past or failed with. Those are important on your history. Your physical exam is your vital signs for sure, but you want to make sure you've organized yourself in a way and engaged nursing staff in a way that keeps track of your vital signs. Your abdominal exam, in case there's a mass arising out of the pelvis consistent with a fibroid uterus. And I think that while you might individualize your speculum exam, and you may choose not to do a speculum exam in a precoital young woman, I think everybody, you should at least inspect the introitus and get an idea of how much flow. The kind of patients who you're going to think about your speculum exam are the patients who maybe haven't had a pap smear in years, or you really think you need an endometrial biopsy because they have other risk factors for endometrial cancer. These patients, you may actually need to get your suction on a tonsil tip and be able to and use it in combination with your speculum exam. So things are going to happen in parallel. And it's really important that it's a multidisciplinary team. I'm sure I don't have to tell you that, but that you are working in parallel with the emergency room team, gynecology, hematology, and you're engaging nurses, the lab, and the pharmacy. So you're putting in your IV and considering volume expansion as you're sending your blood work. And you're sending your blood work for CBC, especially for the hemoglobin and the platelet count, your blood type, and screen, probably cross-matching in the situation that I described. You're going to do a pregnancy test, you're going to do PT-PTT, INR, and you're going to do probably a fibrinogen, not that fancy fibrinogen lab that was spoken about earlier, just a count is what I'm thinking. Von Willebrand screen, and the ultrasound. So if the patient's stable enough, except in the early adolescent when I think your yield is low, if the patient's in her 30s or 40s, I think it's great if you can facilitate an ultrasound. And then you want to set up, like Dr. Winikoff's prototype from Montreal, you want to set up with serial vitals, serial blood work, serial assessments of how much bleeding, and you want to make sure that that's not dropped. I'm mentioning the ultrasound because there is one situation I want to draw to your attention, and I want to go back to that fibroid. Now, if you were looking at this uterus, which is on its side like this, with the vagina and cervix over there, this just looks like a thick endometrial echo. It could be that proliferative, thickened, anovulatory patient. But in this particular case, it does harbor, and this is where I think your index of suspicion, you have to remember, this is a saline-enhanced ultrasound. You may not have time to do this in the emergency setting. This harbors one of these, where it looks on regular ultrasound like just thick endometrium. You could, if you're going to be going to the operating room, or if you're thinking about one of these kind of things, and you don't have saline-enhanced ultrasound, you may be going to the operating room to try to stop the bleeding. You may be going to the operating room for insertion of a balloon tamponade, but you put in a hysteroscope, you'd have to rinse out the blood. You have to have an irrigation fluid. And you might, this is the normal uterus inside, the tubes are coming in up there and there. This is a fibroid and this is a polyp in the cavity. So with or without a bleeding disorder, this can be the reason they've presented. So again, I don't have to describe to this audience what additional testing you might do and when for hemostatic evaluation, liver and serum iron. But I want to stop and take a breath because this basically is your repertoire of treatment options. And we're going to go through it systematically for just a moment. So what you have is medical treatments that are hormonal, medical treatments that are non-hormonal. Remember, I'm talking about the acute emergency setting. And you have surgical or procedural techniques. You don't want to forget antiemetics, you don't want to forget vitamins, iron, and a multidisciplinary team. There's obviously going to be some directed treatments if there's a known bleeding disorder, and obviously there could come, I haven't actually had it happen in this circumstance in my career where you have to go optimize the coagulation profile and go do a hysterectomy, but, oh, I'm sorry, is that dropped? Yeah. So, from this, most patients, bleeding disorder or not, if they don't have a contraindication, you're using tranexamic acid and or an estrogen-based product. The estrogen-based product, yes, there's IV estrogen in that dosing, but most of us are choosing from combined birth control pills or the combined contraceptive patch in this setting. And I'm going to put on as soon as get the blood work going, and I'm going to put on either one patch and be giving tranexamic acid, or I'm going to be giving one tablet of a 30 microgram, and then I'm going to be reassessing 6 hours later. Many, many recipes exist that automatically give the patient 4 tablets a day or 3 tablets a day. I usually will recheck at about the 6-hour mark, and if things are slowing down, then I'm probably going to push to about 8 hours, and I'm going to try to end up with 3 maximum tablets per day. Maximum, or 2 patches per day in combination with tranexamic acid. That's what I'm going to try to aim for. We know that it causes nausea, so again, the antiemetics are really important. And I'm going to talk, so when you do that, you end up needing to transition somehow. And so you're going to end up with whatever routine you have. For me, it's if I've ended up with 3 tablets a day, I keep them on it for at least 3-4 days, back them off to 2 tablets a day, and keep them on that for a few days, and then 1 tablet a day. And you do not want to come to the end of a pack and tell them they take a hormone-free interval and get another bleed. You want to postpone the next bleed. So they stay on 1 tablet a day or 1 patch for at least a month or 2. Then when they take a break, it might only be 5 days. I'll get back to that in just a moment. If you're not winning, or if you have I should say, if there's contraindications to estrogen, you do have oral progestins. I'm not particularly as confident in them, but it's sort of norethindrone at 10 milligrams every 4 hours, or medroxyprogesterone acetate, 20 milligrams. The hormonal IUD is great for heavy menstrual bleeding. It's pretty good for women with bleeding disorders, but it's not that great in the acute setting. And by the way, you don't see NSAIDs up here. As Dr. Winikoff alluded, when we're looking at NSAIDs for their ability to decrease menstrual bleeding, we're looking at them used preemptively and proactively, not in the acute setting. But if you're not winning, I will go to the operating room, put maybe a 15 cc Foley catheter into the uterus to tamponade. I will consider, if the patient truly is one of those very thick endometrium and ovulatory chaos and we're not winning after about 24 hours, I do feel there's a role for a DNC, personally, with a hysteroscope. And I will make sure with hematology we're as optimized as we can. We go, I'll do the DNC, I'll probably put the little balloon in and get out. This is different from what I will tell you about endometrial ablation, uterine artery embolization, and fibroid embolization, and a category of medications directed at fibroids called sperms, so to speak. Okay? Now, the consensus goes on and talks, what do you do if you've diagnosed a bleeding disorder? And what do you do if the patient comes in as a known bleeding disorder? And they give you some examples of what you might do with von Willebrand's. These are more factor hematologic treatments, or thrombocytopenia, or afibrinogenemia. But the reality is, hopefully, some of these patients that are already diagnosed are coming in with what you all are setting them up with a treat first card, and we can look at it and get the recommendations. Before I discuss those last few little items that I want you to hear about for treatment that you might not be that familiar with, that are more gynecology focused, I wanted to just give you what I call my put your money on. So if you've got a teenager, put your money on either the ovulatory dysfunction, a pregnancy loss, or an inherited bleeding disorder. These are the acute, emergent. If you got a woman in her 30s to 45, put your money on fibroids, polyps, adenomyosis, and or a bleeding disorder. And if you got a woman who's between 45 and 55, put your money on ovulatory dysfunction from the transition, malignancy maybe, or pre-malignancy, and or a bleeding disorder. Women may have existed with very well-managed menstrual cycles, albeit maybe heavy. And then when they get one of these gynecologic situations, it tips them over from manageable to unmanageable. So they may not have any of the other past history until they get these problems. So I'm going to be finishing up looking at a few little pearls on each of the blue items. Did you know that Cochrane came out with a 2018 review on tranexamic acid for heavy menstrual bleeding? It is not acute, life-threatening heavy menstrual bleeding, but it looks at low to moderate level evidence, concludes that tranexamic acid is effective for heavy menstrual bleeding. It's more effective than progestins. It's more effective than proactive NSAIDs. It's more effective than herbal remedies. And there's one other thing, it's more effective than that, but it is not more effective than the hormonal IUD, okay? And it only has out of 1,300 patients, one case of a DVT. I think it's important for me to at least disclose that when you're in the acute setting, the benefits of combining these hormonal estrogen-based contraceptives with tranexamic acid usually outweigh the risks. And hormonal combined contraceptives have an increased VTE risk of a relative risk of 2 to 3, but the absolute risk in most patients is low. But no, I can't tell you what the relative risk or the absolute risk is with 2 or 3 birth control pills per day and tranexamic acid. I can tell you that it's usually worth, engaged with your patients, usually worth taking the risk, and we haven't got any evidence that it's a huge risk for an arterial or venous clot. Lastly, on this slide, you have combined contraceptives were always packaged where you take 3 weeks and then take a week off. There was no science to that. This is my soapbox. So it was only designed to make women feel natural, a 7-day bleed once a month. So women, especially who have refractory heavy menstrual bleeding or a bleeding disorder, they can choose when they take their hormone-free interval. They can take it infrequently. They can take it when it's convenient to have a period, and they don't have to take a full 7 days off. For all of these, the patch, the tablets, and the vaginal ring. Uterine artery embolization. This is a procedure done by interventional radiologists in radiology department. Most of its experience is life-threatening bleeding postpartum and or fibroid-related heavy menstrual bleeding. But we do have some experience with success. They go in through the groin and they pass pellets, and they're perfecting their technique with either temporary pellets or permanent pellets to decrease the blood flow to that uterus. In the acute setting, there are case reports that it actually works. It's uterine sparing. And in the past, even in that consensus, they talked about it being something you should not do if a patient wants future fertility, but with more finesse, we are seeing the possibility of successful pregnancies in women who have had this done, especially with temporary pellets, and the fact that there's a lot of collateral flow to this uterus, but it might be worth a try in the emergency setting. With this, I'm going to go in with a scope and I'm going to remove that, but with multiple intramural fibroids, the uterine artery embolization technique may work in the acute and chronic setting, but we also have what we call selective progesterone receptor modulators. They're an oral tablet for fibroid-related bleeding, and you'll usually get a dramatic decrease in the amount of flow within 7 days. That may or may not be good enough. Endometrial ablation, there's many global devices used to reduce menstrual flow, typically used in the women in their 40s to try to get them to menopause without a hysterectomy for heavy menstrual bleeding. It is uterine sparing, it avoids hysterectomy, but is not fertility sparing. In fact, we feel so strongly that we look for women to have some other form of reliable birth control method, whether it's a vasectomy, a tubal ligation. There's a little bit of experience now with using it in the acute setting. it may work for you. And also, we have a little bit more information on putting a hormonal IUD in at the same time and getting longer longevity from that procedure and the birth control. The last topic is the hormonal IUD. So the paper at the bottom is one of our own, showing that in 20 women with bleeding disorders, we had 3 expulsions, which is higher than the baseline rate. And in another, so that's one reason why you probably don't want to rely on it in the acute setting to work right away, but it doesn't tend to work right away. It's got to have time to create the endometrial atrophy that you're looking for. But for heavy menstrual bleeding, there's not a lot of studies looking at women with bleeding disorders, but we are accumulating a few over time. And in this one by Jen Dietrich and her group, they did have 13 teenagers with bleeding disorders, and they had 1 out of 13 expelled the Mirena, again, sort of corroborating that tendency. When you look at all these combined, in bleeding disorder women, you have a high success rate, but it takes them longer to get satisfied. Their nuisance bleeding is more problematic and heavy, and they have a lower rate of amenorrhea. That's the summary, but definitely a good option, and I'm sure Tanya will talk a little bit more about that. So I've really tried to be brief for you. I know these were our objectives at the beginning, to be able to recognize gynecologic causes of acute heavy menstrual bleeding, how to investigate it, be aware of the treatment options that are available and how you choose, and then thinking about transitioning from combined contraceptives, carrying them on for a month or 2, or the hormonal IUD, et cetera. Thank you so much.